We are back for another episode of season 2 of Tell Us More About That. We have two really exciting guests today. This is actually a first for us on this podcast of having two guests in the same interview. So we're making history here. So today we're going to be talking about personality disorder, specifically borderline, and then really where we want to focus most of our time on this interview is on narcissistic personality disorder, what it is, what it isn't. So kind of demystifying some of the stigma around what most people think of when they think about narcissism, and then talking about some treatment modalities, which these two are the resident experts on. Some of the treatment specifically we'll talk about here in a little bit. So today we have Dr. Brandon Unruh. I hope I pronounced that correctly.
Close. Unruh.
Unruh. Gosh, I had two directions and I, of course, chose the wrong one. Dr. Brandon Unruh and Robert Drozek. Did I get that?
That was good.
Yes. Okay, cool. So let's start with you, Dr. Unruh.
Sure. Yes. I suppose just professionally starting there, I'm somehow gotten myself into the place where I'm the medical director of two programs at McLean Hospital that are really specifically geared towards offering treatment for people with personality dysfunction or personality disorders. In one of these programs, the Gunderson residents, we're combining different evidence-based treatments all in the same place. And in another of them, where I co-run the program with Bob Drozek here, we're applying one evidence-based treatment specifically, and that's mentalization-based treatment. And I would just say that I got into this area of working with people with personality disorders, I think in short, just because it kind of touches on everything that I want to think about as a clinician, as a person. It touches on existential issues, kind of core questions about what it means to be a person, to be a human being. And that may sound a bit grandiose, but that's really kind of what keeps me in this particular area of specialization. It's endlessly fascinating and humbling.
Well, thanks for coming on. And then Robert, or you go by Bob, right?
Go by Bob. Yeah.
Okay. Bob Drozek.
Yeah. So I'm a clinical social worker. I'm here at McLean, but do mostly like psychotherapy, and am the clinical director of the MBT clinic, which Brandon has already spoken about. Also kind of help train sort of folks, psychiatrists sort of in training here through another one of our programs, third year psychiatry residents, and kind of how to do MBT and acceptance and commitment therapy. So I've kind of like do several different roles in McLean, but those are the two ones. And then Brandon didn't mention this, but it's good to note that we're both also like trainers and supervisors in MBT kind of more generally. So there's another thing, a lot of what we do is like teaching other clinicians about like how to do MBT through like the Anna Freud Center in London and the Gunderson Personality Disorders Institute.
Very cool. Thank you very much. That's great.
Yeah. Thanks for coming on. But I just remembered the moment when I was like, I'm gonna reach out to these guys and ask them if they'll come on. You said something, Bob, that was so funny. You guys wrote a book recently on MBT, and we'll talk about that for sure here in a little bit. But you said it's the best book on narcissism ever written.
That's
I was
right.
like, that's pretty good. All right, so Jen and I have watched a handful of interviews with both of you because this topic is so complex and there's so many different kind of angles to take with it. But we thought what would be helpful is to start with just kind of identifying on, as we just talked about earlier, like for explaining to a third grader, when we talk about even a personality disorder, what does that even mean?
Such a great question, Brandon. I feel like you're going to be in the best position to sort of speak to that. Like, yeah, what would you say along those lines?
Regardless of what grade one is in, I mean, here is kind of for me, the simplest way to kind of orient oneself towards this concept. I'll try to keep this relatively brief, but first of all, I think it's most helpful just to think about what we even mean by personality. And just to quickly break it down, personality is, we think, probably at the core of what it means to be a person. It is kind of the apparatus that we use psychologically to manage ourselves, to manage our contact with the world, to actually kind of direct ourselves in life. It can be broken down into a variety of subdomains or functions. And I tend to break them down as a segue for thinking about personality disorder. Just think about 4 different domains of personality functioning. So first there's emotion and emotion regulation, and that involves, among other things, being able to look inside and know what I'm feeling, identify what my emotions are, being able to express my emotions to other people in effective ways, regulate my emotions when they get big and sort of out of control. And the second domain is then managing behaviors, managing my urges. Some of my behavioral urges and instincts I need to actually engage and actualize. And then there are some other ones I better hold back if I know what's good for me. I want to sort of be adaptive in the world. Third domain then is the domain of relationship, interpersonally. How do I present myself to other people? How do I make sense of what happens between me and other people? And then a fourth domain is identity or sense of self. And that goes to how I think and feel about myself as a person, somewhat in relation to others, but in relation to the world at large. So if I just think about those four subdomains of personality functioning, that's just part of being a person. And that's what personality normally functions to manage. When we talk about personality disorder, we're then talking about a person for whom there is sufficient instability, usually in all four of those different domains at the same time, such that it actually gets in the way for this person of their own subjective sense of a happy enough, meaningful life. It's preventing them from actually getting to certain important goals or values they have for themselves. It's causing trouble for them at some level, and that usually rises to a clinical level when they present at some point for treatment. That's the threshold between the kind of ordinary personality functioning and dysfunction that we all sort of have to manage, and then personality disorder as a clinical construct and a target for treatment.
Yeah, that's
That was a bit
Thorough.
long-winded,
Perfect.
sorry, but that's
no, that
my
was
start.
yeah, beautifully put. When you kind of frame it in those four categories, when we talk about disorder, is the disorder aspect, do you believe that the way that the DSM characterizes personality disorders, do you believe it accurately kind of captures the people that are struggling with those one of or multiples of those domains?
That's a very good question. I think there's a little bit of controversy along these lines at this point in the field, I would say. The kind of question of the DSM kind of just frames things in terms of categories of personality disorder, borderline personality disorder, narcissistic personality disorder. And you folks might know that in the kind of, as they were preparing the last edition of the DSM, there was a lot of kind of questions. Should we continue framing personality in this way? Because there's a lot of research showing that understanding personality traits as being along a continuum or dimension better map onto the complexity of us as human beings. So I know we're going to talk a little bit about narcissism. There's been a lot of research showing that narcissism is better understood along a dimension rather than sort of as a category. So I guess what I'll say along those lines, and I don't know what you think about it, Brandon, but they're probably overly narrow boxes that don't do full justice to the complexity of the person, and they can be quite helpful at the same time, Like, I think a lot of my patients, when they have been struggling with really significant challenges and then start to actually think about things through the lens of their problems in self-esteem, their certain patterns in relationships I tend to do, they can start to get a kind of deeper window into what might be explaining their challenges that I think patients find actually quite helpful. At least a lot of our patients do. So, there's the empirical answer to the question, then there's the clinical answer, and they don't necessarily there are differences in those perspectives.
And oh, sorry. Just to quickly add to that, it depends a little bit also on which personality disorder or set of traits we're talking about. As Bob alluded to, in the case of borderline personality disorder, there's developed a pretty robust community of clinicians, but also patients and family members and advocates who actually really strongly identify the usefulness of the categorical construct of what it is to have borderline personality disorder. Whereas in the case of narcissism, as Bob just described, actually the consensus in the field is more clearly at a widespread level now that actually we really need to think dimensionally about these things. So it depends a little bit whether you're asking the question more ontologically, like what most accurately maps onto the way nature is, the way personality really works, or what's useful clinically, pragmatically. And those two questions don't always exactly intersect.
I know that personality disorders have been critically examined and their criteria has changed a lot, or it's been renamed or recategorized. Can you give a brief background or a brief history of where it started and where we're going?
Well, yeah, I mean, I bet we could both answer this in different ways. Like, but basically, with the most recent sort of version of the DSM, they're now proposing what we call like the alternative model of personality disorder, which is much more dimensional. It's very kind of influenced by kind of like the 5-factor model and sort of different more dimensional measures about how to kind of look at different personality traits. And where it's going, where it seems like it's going, is that sort of there's still different personality disorders that are outlined in the alternative model, but they're organized around, not to get confusing based on what Brandon had said earlier, but 4 different categories of problem that are unique to each personality disorder. But the categories are identity, self-direction, empathy, and intimacy. And that's sort of like those are the 4 kind of problem areas, and you kind of specify what's the extent of that impairment in those areas. And then each personality disorder has its own kind of additional traits that are sort of specific to the disorder. So, for example, narcissism, there is in addition to problems with identity, self-direction, empathy, and intimacy, there can be difficulties with grandiosity or attention seeking. So in terms of so it's this idea that there are these challenges in these domains, but these unique qualities also associated with people with elevated traits of the disorder.
That
Brandon,
makes
anything you would add about where it's going? Yeah.
no, that makes a lot of sense. Is it something that you think, is it being I guess the evolution of how personality disorders are being identified and then treated? Is it something that's being fueled by research to learn more about it, or is it something that's being fueled more by the need to further, like, specifically diagnose individuals with things that they're seeing? Like, is it more of an exploratory, like, curiosity, or is it something where we want to be able to have more of like a diagnostic approach to handling patients that come in with these problems?
In a way, I think this is something I like about the direction that it's going. And as we are moving more and more increasingly towards this dimensional system of classification and diagnosis, one feature of that directional move is that we have a sense about where personality disorder might be defined dimensionally, but we can also think in what you might say are like sub-threshold, subclinical ways. So we can think about different severities and levels of dysfunction in the interpersonal realm or in the self or identity-based realm. And so, in a way, I think this actually helps us broaden our sense about who these treatments can be for. We're thinking more in the field dimensionally about our treatments as well, so that it's not a one size fits all. If everybody who has narcissistic personality disorder is going to benefit from this particular, full court press treatment package, individual therapy plus group therapy plus family therapy. It's never that one size fits all approach, but that's how we end up kind of showing the empirical validation for these treatments that have been developed. So I think as our sense of what is pathological narcissism and problems in self-esteem, as that becomes more dimensional, we can also apply the elements of these treatments that have been developed at different levels of intensity too. So for some people with lower levels of dysfunction, actually maybe just being in a group is going to be sufficient, where they actually work on their self and interpersonal functioning for a period of 6 months or something, and that's enough to actually get them back to work or managing their intimate relationships more smoothly. Whereas for somebody with a higher level of dysfunction within self and interpersonal relatedness, they may actually benefit from the scaling up of the treatment. So I think that the dimensional application of treatments is going to follow the dimensional understanding of personality functioning.
Yeah, that makes a lot of sense. So we're adding a significant layer of nuance into kind of the way that this is being identified and managed, which seems to make sense with anything mental health related. I mean, very rarely is it all one thing or the next. I heard a couple, the interview that I watched most recently with you guys, and you talked about how there's significant overlap between a lot of these diagnoses, which makes it very difficult for the clinician who's just kind of stuck in a box of just saying, well, it needs to be this, this, or this. That's actually really exciting to hear that it's becoming more subjective to the person and being able to take different pieces and elements of treatments that work.
And in a way, Tony, sorry to barge in, but in a way that gets us maybe to a little bit talking about mentalizing, and at some later point, because we think that there are these kind of underlying aspects of self and interpersonal dysfunction, and there are various candidates for what are the sort of core psychological processes or aspects that we might target in treatment. One of those candidates is mentalizing, and so you get to this notion that maybe some of the treatments that focus on these basic psychological processes like mentalizing might be helpful at being scaled up or down to sort of match whatever the intensity of the difficulty may be for any given person.
Interesting. Okay, that makes a ton of sense. How you all got to the mentalization component of a treatment with this type of disorder. Okay, we will get back to that. I do want to make sure we touch on the specifics, even just as a high-level overview. Can you all introduce, so within kind of the spectrum of personality disorders, now we've got one that's very popular that is also very misunderstood, which is borderline personality disorder. So can you give just an overview, high-level overview of what borderline personality disorder is?
And what it is
Well,
not, maybe.
Yeah.
Yeah, well, let's do this, Brandon. Well, you want to take BPD and I'll take NPD? All right.
Yeah, sure.
Division of labor. Yeah.
Yeah. So, I mean, again, bird's eye view on this, and there are various theories about what is at the heart of borderline personality functioning. Um, we've done a paper on this, actually comparing the different kind of leading theories about what is the heart of BPD and how do we understand it theoretically. But all of the different models that are attached to treatments that are proven to work emphasize something different that they think is at the core. So, for example, DBT, dialectical behavioral therapy, might emphasize the role of emotion dysregulation in borderline personality disorder as one starting point. So, this sense of BPD has this kind of component of um, 0 to 60, getting very quickly into big emotions that feel very overwhelming, that have a very slow return to baseline, that are difficult for the person to actually regulate, that leave a person feeling like, as has often been described, an emotional burn victim. Like, I'm sensitive to my own emotions. I can't tolerate them or manage them. So that's definitely an important piece of BPD, but other treatments and theorists have emphasized other components. So John Gunderson, one of our mutual mentors, really emphasized that for him, at the heart of borderline functioning was interpersonal hypersensitivity. So he saw it and framed it primarily as an interpersonally mediated and expressed set of patterns and symptoms. So for him, this sensitivity to rejection leaves a person who is kind of seeking to be in a more idealized relationship with other people. So they seek out these more idealized connections with others, like the person who will be unconditionally loving and always there for you, no matter what you do. But then in that relatedness, actually, it's very sensitive to discord, conflict, early signs of rejection. And at the earliest sign of conflict or the other person losing interest, the person with BPD will actually tend to kind of cascade down into serious anxiety, anger discontrol, sometimes behavioral problems like self-harm or suicidal statements or behavior. So you see the change in the expression of symptoms comes in response to a perceived or actual change in interpersonal connectedness. So those are just two examples. There are other treatments that emphasize other aspects, but there are different ways to frame this. But in general, BPD is a highly interpersonally contextualized disorder with a lot of emotional and behavioral dysregulation and core problems in unstable identity, like the other personality disorders.
Some of the things you just said could spark a whole nother conversation, but I do have a quick follow on onto one component that you just said. When it's this idea that somebody is almost like hypersensitive to other people's perceptions or hypersensitive to their judgment, or are their perceptions, do you find that they're normally accurate, or do you find that they're overinflated perceptions of somebody being like critical to them, or what's kind of
Yeah.
the issue that they're landing on there?
This is a great question, Tony. There's a lot of research we could touch on here, but just to give you a few beats, there's good research indicating that when people with BPD are shown facial expressions, some people, listeners might be familiar with the Ekman faces, thinking about, this background in interviewing and profiling. When people are shown facial expressions that people without BPD would tend to characterize as neutral or resting faces that don't seem to have a lot of emotional content in them, people with BPD are more likely to actually perceive criticism, malevolence, judgment, aversion in these faces that others would experience more neutrally. And this plays out when a variety of other research studies show that when people with BPD are actually given cues of exclusion or social ostracism, that there's a larger than average emotional reaction to that, that the pain of feeling ostracized or criticized or judged or left out in particular, left out of kind of social dynamics, isolated, that pain of loneliness and emptiness is particularly dysphoric and intolerable for people with BPD. They're more likely to perceive ostracism, criticism, exclusion, when in fact, in the mind of the other person, that may not actually be at all what is being intended. And I could say more. There's a lot more research on that point, but I'll leave it there for now.
So they're drawing the wrong conclusions. They're like acutely they're looking for even just one component that may validate their fear of how this person may be evaluating them. They find it and then they narrow in on it and discredit all the other variables that would say otherwise.
Yes, in a way, and I should qualify. It's not necessarily wrong, because often people with BPD are actually very sensitive and accurate about picking up emotions in other
Mhm.
people. But there's this concept called the borderline empathy paradox, where people accurately pick up that the other person is experiencing some emotion, but then have a greater than average difficulty of contextualizing what that emotion in the other person is about. So are more likely to misread that as being personally about them.
Yeah.
Whereas actually the person may be anxious about something else, but not writing off the person with BPD as a bad, terrible, unlovable person, which is where the mind of somebody with BPD tends to land rather quickly.
Well, yeah, and this is a great this very much relates to the idea of mentalizing, and there's tons of research to your question, Tony, about problems in mentalizing for folks with borderline personality disorder. And one of the ideas is that it's not that it's an inaccurate kind of reading of others' mental states, but it's an overly narrow one. So if I have sort of like 100% of emotions in me, right? If you have BPD, you may be attuned to the 5% that sort of that like judging you, right? And that encompasses your experience of me. But there's this other 95% that is not as much on your radar. And so a lot of the work and the clinical work with these patients is how can we expand the array of the parts of the other that the person is considering?
It's essentially like just they have tunnel vision and they're just looking for that one thing that they don't want to see, but that's all they can focus on. And you guys, the mentalization is just broadening that aperture.
Absolutely. Yeah,
Okay,
it's a huge part of
interesting.
it. Yeah.
Have you found, and I know it's different.
And I sit down with somebody and I'm getting to know them when they have borderline personality disorder. Um, a typical story would be a really tragic one that has within it many experiences of actually feeling quite left out, misunderstood, invalidated, quite separate actually from the kind of continuity that they perceive other people have going on around them, that they can't be part of. So there's a sense of otherness,
Yeah.
differentness, separateness. There's a famous paper by Mary Zanarini called "The Pain of Being Borderline," that actually really goes through and describes, through asking people with BPD, what do you feel and think, as throughout the day? And actually, people with BPD are just much more likely to report having judgments about themselves and emotional experiences that are of the kind of seeing themselves as unlovable, fundamentally flawed, evil, different, inferior. These kind of experiences are very much, actually there and happening. And it becomes a vicious cycle because, of course, for anybody who's experienced so much of rejection and misunderstanding, of course, there's going to be the adaptation to actually pull away from certain kinds of circumstances or protect oneself against certain circumstances where one expects that that's likely to happen again. So you do see how the genuine experiencing of being separate and different and rejected then colors the interpersonal adaptations, which then, of course, double back and actually can contribute to further experiences of rejection and separateness. So it becomes a really challenging, painful cycle. Yes, absolutely. And I'll be quick on this, but yeah, for somebody who for whom the problem has been that nobody has understood me. There hasn't been anyone there I could count on consistently. The solution can seem like searching out and finding that person who will be unconditionally present. So, that desperate search for a relationship in which there will be that unconditional acceptance and connectedness, you can hear how that becomes very fraught because no human being can live up to that ideal, but you can also hear how it's a very understandable position for a person to end up in, searching desperately for that ideal and looking to find that in other people. Yes, and this relates to the heart of what we think, according to some theories, is going on that actually explains borderline level difficulties, which is called splitting. And splitting refers essentially to the intensely polarized, separate, usually opposite representations of self and others. So when there's a really painful conflict between somebody with BPD and someone else, the two kind of binary extreme ways of making sense of that in the moment for somebody who struggles with splitting is going to be to either see oneself or the other person as the problem. So if the other person is the problem, then there's a little bit of hope that maybe I could keep looking and find somebody who's better, will be better than this person. But if I'm the problem, then actually that's a deeply hopeless place for someone to be in that tends to actually be associated with the descent into self-harm, hopelessness, and more serious suicidality. So those representations of self and others, am I the problem? Are you the problem? Am I bad? Are you bad? Are actually, when that becomes very unstable, that's where we as clinicians, think more about safety issues. Splitting is something that we all as human beings experience and our minds do. It is kind of one of these very classic and universal defense mechanisms, but it is more characteristic and more common, and you could say kind of problematic, harder to get out of for people who have borderline level personality functioning. And that includes not just people with BPD per se, but a variety of other personality disorders as well.
Let's pivot over to Bob for kind of the high level overview of narcissistic personality disorder.
Yeah, well, it's difficult to get too high level because it is a complex and often misunderstood construct. Narcissism is with a lot of kind of controversy and murkiness. But I'll just to start, because I know there's the discussion about the DSM. If you were to like Google like narcissistic personality disorder, you're gonna get a bunch of criteria. The categorical model that we mentioned earlier of narcissism, that really that skew very what we call like grandiose, the grandiose subtype of narcissism, where the person kind of feels superior to other people. There can be significant tendencies towards dismissiveness, I'm better than, overt efforts to get attention from others. So that model of narcissism has been kind of widely seen as only representing like a smaller sort of subtype of or subset of sort of folks with narcissistic challenges. And with the development of like, a lot of empirically validated measures for narcissism, folks have found that there's a whole nother subtype, which is sort of the folks that, we probably, proportionally end up seeing a lot here at McLean, that we end up sort of treating a lot of, which is called the vulnerable narcissism, which that's sort of where the person, it's not that the person thinks that they're so great. It's more of a conditional sense of self-worth, which is I am only valuable if. I'm only valuable if I look a certain way, if I have a certain degree, if you're seeing me in a positive light. So it's called contingent self-esteem, which is one of the kind of backbones of vulnerable narcissism. And contingent self-esteem looks a lot more like borderline. When Brandon was describing sort of BPD, there's this idea that there's a disruption in a relationship and I'm unstable, right? With vulnerable narcissism, it's this idea that I don't meet my standards for self-esteem and then I'm unstable. So it's sort of instability, but instability caused by disruptions in self-worth. And what that can lead to with vulnerable narcissism is there can be tendencies towards avoidance. The person can try to stay away from anything that makes them feel bad about themselves. Also, they can get angry because, if their worth is only conditional and somebody threatens that, there could be a tendency towards arguing or trying or getting into conflicts with others, getting dismissive of other people. So these are our two broad subtypes. What joins them, and this has been shown through research, is both sorts of narcissism are marked by what it's called antagonism, but really what that means is some elevation of self over other. Where there's sort of problems in empathy, a little bit of self-focus, where the self is a little too big and other people can factor in less prominently in the person's experience. So both subtypes kind of share that in common, but they look a little differently.
Interesting. Okay, I was trying to find the tether between the two, so that makes sense. This kind of uh, poor evaluation of their role in society is essentially kind of what it's getting at. So people, the vulnerable narcissism, I actually hadn't really heard much about that until I heard you guys talk about it. And it is interesting because I think when we talk about narcissism, and if you were to throw a poll out there and ask people what it is, I bet 98% of people would go with this kind of grandiose, the part that the narcissism that's constantly vilified. Whereas this one is just a fragile sense of self. Like they are trying to put that confidence onto something else, and when that's gone, they judge themselves for it.
It's a good question. Fragile, it leads to fragility, but I would say it's more of like it is what's called contingent self-esteem. So it's actually a degree of rigidity. It's I am only valuable if. So it's like the only way I can feel good is if I meet certain criteria. I feel good about myself if I meet certain criteria. So what that means is that when I meet them, I can feel good, but when I don't, there is no self. So it leads to sort of fluctuations in self-worth, but it's a result of being a little too, again, narrow in like how I see my own value.
Okay. So and this may be totally off base here, but like the first thing I thought of when you said this is people who struggle with kind of they pour themselves into their identity as one version of themselves. So what I was thinking about with like law enforcement or military, when they get out of those roles, they've identified as a soldier or as a cop or as a detective, whatever it may be. And you see this with, all sorts of people in relationships or whatever else it may be. But how do you kind of differentiate between the person who's really struggling with, I can't get out of this because if I do, I'm going to be worthless or have no value, versus someone who's actually has this sense of like vulnerable narcissism where it seems like that would be deeper?
A really good question. I think both of us should answer that one, Brandon, because it's a thoughtful question, Tony. So what I would say is we got to look at the person's life as a whole. So this is the question, like you're talking about a complex life circumstance, right? If any of us were to lose our career or have to give that up, that's going to be dysregulating. We may have a sense of like, who am I? What should I be? With contingent self-esteem though, this sort of conditional sense of self-worth, usually there are problems independent of that particular life transition. Right? So you look at like, you'll find, and this isn't always the case, but like challenges with interpersonal relationships at work. So, like, if other people don't see the value of their contributions, they can get a little more resentful, right? There can be a tendency towards arguing with others. There can be a need for things to be done in a very specific way that leads to disruptions at work. Similarly, right? Like, if somebody with narcissism, they can really prioritize, and we all can to some degree, but definitely pathological narcissism, people seeing them in a positive light, right? That works well, for the first few months of being in a relationship. But like, as all of us know, what happens when we're in a romantic relationships and our partner doesn't see us in a positive light, right? And then there's a tendency towards dismissiveness, argumentation, right? Telling your partner you're wrong and this is why. So in order to kind of distinguish and kind of get at what you're asking at, Tony, we kind of go across these domains, and do we see these processes playing out apart from just the unique life event? Yeah, Brandon, would you add anything about that?
No, very much agree with that. And just to bring in quickly the concept of healthy narcissism, which again, is helpful to keep that in mind when we think about dimensional self-esteem issues. So as Bob said, we all would struggle at the loss of a professional role. But healthy narcissism is, you could think of it as the capacity to, retain or return to positive enough feelings about ourself, our self-image, the way we evaluate ourselves in light of these kind of ordinary life, vicissitudes. So somebody, is going to struggle with that on a dimension. And as Bob said, we look across the different domains of functioning. And again, this notion of personality disorder means we're not just looking within the lens of identity and how self-esteem regulation happens within the person's interior experience. It's also, how is this instability expressed interpersonally in their ability to direct themselves around obstacles that happen in life, move forward with other goals? How are they in general with intimacy and relationships? These sorts of things.
How regular is it for you to treat patients with the grandiose narcissistic type?
Well, it's a great question. I mean, it's more like what prompts the person seeking treatment. And so I'll say is, with vulnerable narcissism, there is a lot of overt pain. Like the person, because if the person is not meeting their standards for self-worth, they feel very, very badly about themselves. And so that actually, there's a lot of research showing that vulnerable narcissism correlates with depression, anxiety, and emotional dysregulation. So when folks are experiencing those things, they want treatment, right? So we have tons of people, and I think that's why we probably end up treating more vulnerable narcissism in the clinic and in our programs than the other subtype. That said, grandiose narcissism, we still kind of treat folks with those sorts of traits and challenges. They're more likely to present to treatment when the world gets upset with them and is kind of saying, hey, the way you're acting is problematic. We want you to seek treatment. In my experience, they can still absolutely be treatable if we can help them see the ways in which their challenges in their relationships and difficulties relate back to problems and sense of self. And if we can do that, patients are totally often like, for example, we see, somebody who can be very dismissive of his wife, and then you starting to see, well, isn't there a way, like, what did that feel like for you? When she had made that comment, well, it just wasn't right. She shouldn't have said that to me. I said, but what emotions did that bring up in you? And then you can get to feelings of hurt, get to feelings of insecurity, and how there's an always need to dismiss when those come up. And then we're in business because the person is able to see, okay, these problems in my marriage are linked to something going on in me, not just in her. And as long as we can get that going, I think these folks are totally treatable. But it's a big question. Sometimes we can get that going, other times we can't. Brandon, what's your experience with that?
No, I just absolutely agree. And just add that this is a real distinction, I think, clinically between BPD and NPD, because people with a more primarily borderline organization tend to, not always, but tend to kind of, in a way that I don't want to say are more comfortable with the painfulness. It's not comfortable at all, but are more likely to express the painfulness that they're living with outwardly in interpersonal ways that actually other people can be moved by, can be moved to help. Most people with primarily narcissistic organization, um, the pain tends to be more compartmentalized subjectively. So, as Bob's suggesting, the techniques that we have to use often have to be a bit tweaked towards actually helping a more narcissistically organized person kind of get into their painfulness. Would you agree with that, Bob? There's
Absolutely.
actually kind of more walls and compartments up that the person has, it's kind of erected as a survival strategy. You can think of it that way. So they're more walled off, actually, from the subjective sense of pain. That's more true in the grandiose subtype. So it can be more challenging to actually get to a place where both the clinician and the patient are looking at the pain and its source together. That takes a bit more work, we find in NPD as opposed to BPD.
So is it you find it's more with the BPD versus NPD? Do people with narcissistic personality disorder, is it that they are intentional with putting up those walls more often, or is it that they're less introspective and they just don't know to like take a second and have a thought about their feelings?
It's a really, really good question. And we do have actually a scientifically grounded answer to it, which is that narcissism, uh, there's tons of research showing that narcissism correlates with what we call alexithymia, which is difficulty identifying, recognizing, and expressing emotions in self, which is not what we tend to think about when we hear the stereotype of narcissism, right? Which is the person who's me, me, me. And there is some selfishness, obviously, in narcissism, and there's often a really impoverished internal world. And our theory of narcissism, which we wrote about and published about in the book, and this is supported by research as well, is that these folks have often not had relationships where their emotions were adequately mirrored. But that really matters because the whole MBT's model of emotion is that the only way for me to know I'm feeling something is if I had a relationship with somebody who saw me feeling it and mirrored it to me. And so the idea is, for all intents and purposes, when these patients are starting treatment, it's like you're telling me, like, Bob, why don't you speak Chinese? And I'm like, I haven't heard it. I don't know it. Like, it's the same sort of problem with emotions and narcissism. So a lot of the early work that we're doing with these folks is helping them understand what's going on with them. So I actually think that with most of these patients, it's not intentional at all, actually.
Do you find that you or other clinicians experience a lot of pushback or challenging or resistance at the beginning stage of this treatment?
Yes, and I think we try to, in a way, formulate it not so much as pushback. I mean, we can certainly experience it, and this can sometimes reflect maybe our own difficulties in understanding our patients accurately. We might experience a piece of interpersonally off putting behavior as being intentional, consciously driven. And as Bob's suggesting, actually, much of the research suggests that actually a lot of these interpersonally dismissive or off putting or self enhancing behaviors are actually more reflexive and automatic. And so this is where we have to actually kind of keep ourselves in a decently reflective, humble place. And in MBT, which we kind of come back to, we use this not knowing stance. We try to actually ourselves be not knowing about where a particular behavior is coming from in a patient, but actually try to kind of hold it up for shared scrutiny together and actually reflect together on, like, what did you mean actually when you told me that, like, I'm the sort of like worst, clinician that you've ever met with who doesn't, you know, I mean, that sounds stupid the way I put it, but like, sort of, where were you coming from? What was going on for you first? And what was your sense about, actually how that might affect me? And we do that in a particular sequenced way in this particular treatment.
I would propose, Jen, like, in some ways, we are hoping that will happen in the treatment, I would say. Because in some ways, like if it's not happening, then most likely we're just in the idealized role to speak to the splitting language. But we really need the patient to start to bring some of these processes into the relationship with us so we can use the approach that Brandon's talking about. So if that comes up, I'm personally very grateful for the devaluation because it's going to give inevitably it's arisen elsewhere, and now we have a chance to actually look at it and help the patient with it.
Master's programs, you learn the basics of the major diagnoses, but limited in terms of how to actually, like, how to be confident and competent in this type of diagnosis specifically, like having that challenge or that push and pull in a session would be really challenging for clinicians, I imagine.
One of the things I think we both learned from, again, one of our mentors, John Gunderson, was, when we have the internal tendency to lean out or lean away when something's happening in the room with the patient that we're daunted by or we feel kind of injured by or we don't know what to say, instead of leaning out or away, actually lean in. So try to actually sit forward in the chair and lean in with curiosity and interest to explore. And as we do that, generally I find that there's something to empathize with. There's actually there is painfulness in there or around here. It just may not be writing on the surface, so we have to kind of dig for it a bit to understand it and look at it together.
Sense too, because clinicians are humans, and we have our own lived experiences and our own things that, like you said, are feel like a challenge, but maybe aren't, right? So it's got to be hard to sit in that and to lean in when everything in you is yelling, this isn't okay. We got to lean out.
Yeah, and actually, I along those lines, I just wanted to look it up because there's been some good research on your point, Jen, which is what are the typical countertransference emotional states for therapists working with narcissistic patients? I just like looked it up, and just to kind of note that the most common sort of emotional states, like I didn't pull up the right study, but it's basically a sense of sort of hopelessness, frustration, anger, futility, and negative feelings about the self. Like those are the common countertransference experiences for folks working with narcissistic patients. So that's a key. It's something we need to really be mindful of in doing the work.
I think this is a good. I know we're not going to be able to get into it very deep, but just to kind of touch on. So from a personality disorder perspective, we talked about borderline, we talked about narcissistic personality disorder. When it comes to the MBT and what you guys have specialized in and really kind of spearheaded a lot of the more recent research, how have you found that has this direct nexus into being such an effective treatment for these issues?
First, can we explain?
That's fair. Yeah. Can we explain what it is?
Good question. Well, Brandon, do you want to take mentalizing, then I'll talk about MBT, and then we'll go from there? Yeah.
Yeah, absolutely. I mean, so I love every time I'm asked to sort of define, what is mentalizing, because the more I think about this, the more I've kind of become convinced that this may be the most basic thing that the mind does. Sounds like a bold claim. But I'm hard pressed to sort of name something at the level of mind and experiencing. I'm not talking about what's going on between the synapses, neurobiologically. Of course, there are more rudimentary biological things happening, but at the level of being a person, the level of, phenomenology, experiencing ourselves and others as persons, mentalizing is a good candidate for the most basic psychological process that we're all engaged in, actually all the time at different levels, whether we know it or not. So if you sort of start with that, mentalizing is a basic universal thing that all of us are doing much of the time automatically. Well, what is it? Well, and Bob actually kind of came up with this nice way of saying it, that it's about reading, accessing, and reflecting upon mental states. There's various definitions that are out there in the literature, but I really like that one. It's pretty conversational. Reading, as in registering, accessing, as in having some emotional connection to, and then reflecting on mental states, just meaning the kind of stuff that happens inside myself and inside other people. So we have various ways of paring this down, even more simply, when we talk about it with patients, we often say seeing others from the inside and seeing ourselves from the outside, which gets at a lot of the different facets of mentalizing, not all of them, but it takes us in the direction of empathizing with other people, having a sense of what is going on inside others that may be very different from what's going on in myself at the moment, having a sense of how do other people experience me, which is quite different maybe than how I'm experiencing myself. And this we think is the bedrock actually for having, satisfying, sustaining relationships and also a coherent, stable sense of self. So this is bedrock for having a stable bit of personality functioning and kind of managing to get through life.
Could you differentiate that between someone's concept of empathizing?
Yeah, well, empathizing, we would say, is a part of mentalizing. Mentalizing is undergirds the activity of empathy, which itself can be broken down in various ways. The research will sometimes draw a distinction between cognitive empathy, which is sort of the more intellectual, thought-based appraisal, like I've done something that that person now feels has hurt them, right? But that can sound kind of robotic if it's purely intellectual. Whereas emotional empathy has to do more with the subjective experience of kind of, I am impinged upon emotionally. I'm actually emotionally affected by or connected to the suffering I perceive in that other person. So those processes can be broken apart, and actually, people with NPD tend to struggle more in the realm of emotional empathy, whereas they can actually be quite strong sometimes at cognitive empathy, accurately labeling what's going on inside other people, but not in a way that actually connects back to their own subjective emotional states.
Okay.
Yeah, and when Brandon said reading, accessing mental states and self and other, the empathy is the accessing part, right? So it's like not only am I seeing that you seem, a little sad, but like I'm actually caring about it and resonating with it. Both are parts of mentalizing. So I would say empathy is like a species of mentalizing in a way.
God, man, that's a really, really interesting distinction because empathizing is one of those things that kind of just gets thrown around, and people don't really truly seem to, I think, conceptualize what it's actually getting at. But that kind of two-way aspect of not just being able to accurately identify, but then to be able to really process and accurately understand how that may be affecting them, and now how that's affecting you, and now how you're affecting them by how you're responding. So like that whole calculus is okay. That was very helpful.
So that's the idea of mentalizing. And then to get to MBT, which I know we got to stop shortly, but we want to be able to kind of cover this a little bit, is a lot of research shows that all of our personality disorders are associated with deficits in mentalizing. And it's different deficits associated with different personality disorders. And we, could get more into this, but essentially that's MBT's model of personality pathology, which is that it's really the mentalizing shuts down. And then we start to see all the instability that we talked about earlier, right? So if I am not connected to my own emotions, I'm going to be more reactive, right? Or if I'm not reading you and my impact on you, I might be more aggressive. Or if I feel really certain in my perspective, my perspective is the only way to see it, I'm going to be more rigid and dismissive of you, right? So it's like the idea, MBT's theory is that problems in mentalizing are really the ground of all the sorts of instability that we see in personality disorder. So what the therapy does is we try to kind of help folks essentially in areas where they feel insecure or kind of where they struggle with difficulty. We just are trying to get them to reflect on mental states. That's the primary aim of MBT, is strengthening the resilience of patients' mentalizing capacities so that when they get revved up, they can start to reflect. And we wrote this in the MBT for Narcissism book, to reflect rather than reflex, right? Like rather than just react, we're going to pause to consider. And what the research on MBT shows, definitely for borderline, definitely for antisocial, and sort of like, one study for narcissism with traits of narcissism too is that results in significant functional improvements for folks with personality disorders. So that's kind of what the therapy aims at.
It seems so obvious too. Like it's wild that it's when you say it and you package it in that way, it's like, well, yeah, clearly their problem with thinking about their perceptions or their feelings or their inability or refusal, or other people's. So man, it sounds like it has application well beyond personality disorders, anxiety or PTSD. Anytime someone kind of gets that reflexive reaction, and then you guys are teaching the fail stop, right? Like before you do this, let's think about why you feel the way that you feel, which will change the way you're going to respond to it, type thing.
Definitely.
Okay.
The ones that I mentioned, that's where the most sort of research kind of supports those things. But MBT is applied very broadly to depression, to anxiety. I know you were talking about law enforcement officers earlier. We've developed it for law enforcement violence and sort of like trying, like, can we pause to reflect there, So there's where our hope is that by kind of stimulating these sort of reflective processes that we're going to be able to help, improve just sort of people's emotional and interpersonal experience.
And the developers of MBT in London, Anthony Bateman and Peter Fonagy, have gone so far as to argue that probably in any successful psychological treatment, there's going to be a common denominator of good mentalizing happening between the within the therapeutic dyad, actually, that this is likely to be a common factor in psychotherapies that work, certainly for personality disorders, but likely it's just part of good old-fashioned plain therapy 101.
Wait, what'd you say, John?
I said, but I feel like a lot of therapists don't know that it has a name or it's got a structured framework.
It's true. Well, one thing we should mention about one of the things that is, I would just sort of, if a lot of the listeners might be new to MBT to that point, that we should mention one of the most idiosyncratic things about MBT is what's called the not knowing stance, which essentially is the therapist is prohibited from filling in what patients are feeling. We're not allowed to do it, which is very hard because if we're not reflecting on feelings as much, it's tempting to be, doesn't that really make you feel ashamed? We call it co-opting the mentalizing. What we've got to do is come up with a question that would help bring the patient's reflectiveness online.
Yeah, like motivational interviewing aspects of that as well, drawing it out of them, using what they say to help them understand their perspective.
That's so true. Yeah, no, there's definitely overlap between MI and MBT.
And how many times when you guys are going through the beginning stages of this treatment or this process, you have someone in the room that's like, well, what the hell? What did I hire you for? If you're not going to give me this answer,
Exactly.
why am I being done?
Which is another green flag that they're pushing back. So.
Yeah, there we go. We're devaluing.
Right.
Not only is it great when we get those kind of, irritated reactions, but we lean into those moments and we'll say, you know what, that is a great question. Maybe that's the question, but actually what we have to do together is, rather than me kind of try to pull something out of my pocket to give you an answer, first of all, it may not be right. It would be kind of BS if I did. Often it would be the case. But actually, you and I have to be curious together about that. We have to take that as an active question about which we're both going to try to be curious together. And that is a kind of common starting point, is turning these rhetorical questions people will throw out into actual questions and actually generating and sustaining that kind of curiosity within the therapeutic relationship.
Well, and to that point, I would say, then I may want to give an answer to that question, but if we're going to be in the not knowing stance, I'm going to then say, okay, this is a fair point, like Brandon's saying. And let me ask you, do you have a sense of what would lead me to ask you this question rather than just saying it? What do you think? Right? That's essentially the move. That's essentially turning it into a question to kind of bring mentalizing online.
I have two questions, and then I know we will wrap it up. The first one is there a sense of this where when someone comes through this type of treatment, where you're setting the table or laying a foundation, kind of priming the client so that they understand what this process will involve. So like if they ask a question and you're not going to give them a direct answer, because by design, that's not how it works, that you kind of tell them this is an environment of like shared humility, shared curiosity. We're going to learn together. Like, is that an element of this?
Bob, you better take this one.
All right, okay. And I should let people know I'm running a group at 3, so I have to hang up then.
Yeah,
if
yeah.
that's
Okay, that's
but
kept you long.
yes, there's a whole kind of, actually I should let, not to self-publicize, but I do have a new book. Is that why you gave it to me, Brandon? Because the book?
Yeah.
Brandon's been so nice.
There, Bob. Yeah.
Well, so I just
Mentalizing you and thinking maybe this is the time.
That's so he's mentalizing. Very nice. So I basically, one of the things about MBT, and I think it gets to your point, Jen, of like therapists don't necessarily know about this, is that unlike DBT, which has these wonderful, very elaborate skills training manuals, there's been no books written for patients about how to do mentalizing. So, and I do think that's affected people's level of awareness of the treatment, despite the fact that there are so many scientific studies showing that it's effective. So, next month, I've written what's going to be like the first book for patients about how to do MBT in their own lives, based on the model that we first outlined in the narcissism book, but applying it for folks with BPD and other personality disorders. So the hope is that, yeah, absolutely, you're totally right, is that we need to do some psychoed so that patients understand why we're doing this, and then ultimately, hopefully, can help them be curious about these processes too. But there's a lot of, in the early stages of MBT, we've got to help patients understand why we're doing what we're doing, which is mentalizing.
Well, I want to be respectful of your time, and I only have 3 minutes, so we can.
We've already
disrespected your time.
It was fun.
I don't think we don't feel disrespected.
Oh,
No,
Okay, that's good. So we
conversation.
did a good job disrespecting
Yeah.
you, because you're not walking away feeling disrespected. That's great. You guys were. I mean, this was so much fun.
thank you both so much. This has been fantastic, and I can't wait to read your book.
Cool. Yeah. We'll send you. I'll send your way when it comes out.
Maybe the last thing we could do is you could just let us know, like, where people can find the research. Are there, any kind of resources that are available? People can.
This will sound like me as Bob's friend, just shamelessly plugging him again. But honestly, I think that's going to be a really pragmatically welcome resource. I think in terms of a clearinghouse of sort of like concepts and pulling the research together and practical tips about how to do this mentalizing thing. But beyond that, the Anna Freud Center in London is really the birthplace of mentalization-based treatment as a system, a model. Let's see, what else did we put out there?
Well, Brandon, MBT Boston, they can check out. We have a website, and it does include like all of our publications. It includes links like to videos of sort of folks doing the therapy and stuff like that. So check out MBT Boston, and also other resources about sort of doing MBT. Once the book is out, that'll be there for patients. But a lot of the stuff, at least in MBT Boston, is geared towards clinicians wanting to learn more about the model.
Thank you. That's perfect.
Yeah, we'll close it out. But thanks again, guys. This was awesome, incredibly informative. So great chatting.
Awesome. Nice to meet you both.
Thanks for having us. What a
Great to meet
joy
you.
to talk with you. Thank you.